Доброго вечора, українські радіаційні онкологи, медичні фізики, радіаційні терапевтичні технологи. Слава Україні! Дуже дякуємо, що приєдналися до SBRT SRS course with Astro APM Experts for Ukraine. Help Ukraine Group, Astro International Committee, APM Clinical Education Subcommittee, RISE Contra Cancer with SweetCare support. We are all excited to present this third lecture in the course. The topic is very interesting, I think, for all radiation therapy professions. And the topic is immobilization, motion management, and image guidance. So we have two amazing speakers from my home institution, Stanford. First speaker is RTT. He's an amazing RTT at Stanford, Joshua Langer. Joshua has been a radiation therapist for 17 years, and he is a great educator, participating in educational activities at Stanford, RISE Contra Cancer. Is also presented nationally on IGRT techniques to improve patient outcomes. Following Stanford Medicine mission to educate, Joshua regularly presents during Educational Week at Stanford Radiation Oncology Department, and he also participates in outreach with local students interested in STEM careers. He's currently training to become a dosimetrist in our dosimetry group to develop high quality plan for our patients. Thank you so much, Joshua, for preparing this lecture for us today and for teaching us. So we are very excited to learn from you about immobilization. And our second speaker is Dr. Laurie Skinner. He is a clinical associate professor at Stanford with clinical expertise in external beam radiation therapy, including advanced motion management techniques and MRI-guided radiation therapy. He received his PhD from Bristol University in the UK. He came to US to work on synchrotron X-ray scattering research with Stony Brook University in New York. In 2015, he switched to the medical physics and obtained ABR certificate at the University of Chicago before joining medical physics residency at Stanford. He's a superstar in our department. His research interests generally revolve around developing novel devices for advanced clinical practice. He is a pro in 3D printing. And the examples of his projects include personalized 3D printed electron beam collimators, rotating couch overlays for total body radiation therapy. He did an amazing job on this project, and radio transparent audio visual communication and immersion displays. We call them avatars for pediatric patients. So he has kindly created the avatar for Okhmadit Children's Hospital in Kyiv, and we are very grateful, Lori. Thank you so much for supporting Ukraine, and thank you again for preparing this lecture on motion management and image guidance for us today. So we are looking forward to learning from both of you. So we'll start with Joshua on immobilization. I'll stop sharing.
And I'll start sharing. And thank you so much, Natalia, for the welcome. And I'll start speaking now about simulation and immobilization for SRS and SBRT. And I would like to just say thank you to everyone in Ukraine who is attending the lecture today. And you are brothers and sisters over there, and our hearts go out to you in your clinical efforts and otherwise. And Slava Ukraini.
Героям слава!
So just a quick overview for what I intend to cover today. I'll give an introduction, introduce the role of radiation therapists here in the United States, talk about general practices in CT simulation, because sometimes what we do to prepare for simulation is just as important as how this simulation is executed. And then we'll focus on how we simulate and immobilize for SRS cranial targets, and how we simulate and immobilize for extracranial targets, which is SBRT. So I'm not wholly familiar with clinicians' the way the clinicians' roles are in Ukraine. So I just wanted to make sure that everybody knows what a radiation therapist does in the U.S. And I'm speaking as a radiation therapist today, even though I have received some further training lately, but my expertise is in the radiation therapist role. So we are a radiologic technologist who is focused on, first of all, treating the patients safely and accurately, and being able to realize what's going on with the treatment plan. Now, after some time treating patients, often the radiation therapist will have the opportunity to work in the simulation, which is, as you know, very important for casting the mold, so to speak, of how the patient's treatments will unfold over their course. So my experiences as RT were first in a community hospital in Wisconsin, which is near Chicago, and we treated about 30 patients a day. And we did have some SRS and SBRT at that hospital, which I think is interesting to talk about because of the way we were doing things 15 years ago has considerably evolved. And so in the late 2010s, I started working at Stanford, where there's a much more robust uh, treatment service for SBRT and SRS as far as volume and technique. And then it is another 15 years since I started. So techniques have evolved, and we have a lot of exciting new platforms for SRS and SBRT delivery. Okay, so brief overview of what we're working with at Stanford. So all of our patients are simulated on a Siemens Biograph 120 slice PET CT. We don't do PET scans for all of our patients, but we use the same machine for all of our scans currently. We have 4 platforms that are currently delivering SBRT and SRS. The CyberKnife handles 99.5% of our cranial and spine SRS. Our TrueBeams also treat a lot of the SBRTs, and occasionally we treat an SRS on TrueBeam, and I'll talk more about that later, about how we differentiate the setups for those different machines. We also have the reflection machine, which is capable of delivering SBRT treatments, and the ViewRay Meridian, which we do a lot of our SBR treatments on now too. And I'll talk a little bit more about that as we go along. And let me just say quickly that I may vacillate between using SBRT and Sabre, which is our preferred nomenclature for SBRT at Stanford. So, but it does mean essentially the same treatment. So I'm going to try to say SBRT during this talk, but I might say Sabre once in a while. SABR, which stands for stereotactic ablative radiotherapy. So where are we? Here we are. We are towards the end of this arrow over here, and we're well past the era of 2D radiation therapy, well past the era of 3D radiation therapy. We're well into the era of IMRT, SBRT, 4D radiation therapy. So this diagram just kind of, everyone can probably realize what this diagram is showing is that the margins are shrinking. And so that has allowed the development of SBRT particularly, and the development of SRS as well. So one of the themes I just really want to bring home in this talk is that not all centers are going to immobilize the same way. It really depends on the tracking, and Laurie will get into that in his lecture. So if this all makes sense to everybody, I'm just trying to say that the amount of immobilization needed for SRS and SBRT is inversely related to the ability of you to correct with IGRT, with your couch correction, or manual repositioning by the team, and as well as the tracking during treatment. So the more you're able to correct the position and track the target, the less immobilization is needed. And that's the theme we see with uh, the development of SBRT specifically over the years, and SRS too. And I'll talk about SRS. So as I alluded to earlier, I think everybody knows, but like what we do before simulation really sets us up for the whole treatment course. So we rely on our physicians to assess the patients and determine what can be done. Usually for SBRT and SRS, they're going to want contrast. Not all patients can get contrast due to medications that they're taking or other problems, but the safety, setting everything up is really important, as well as determining which patients are going to be able to hold their breath. If the patient has some comorbidities that are going to prevent a good breath hold, it's good for the physician to be able to see that ahead of time. And then, so sometimes we'll see that certain patients aren't going to even get a breath hold ordered, even though it might be helpful for their simulation. If they can't do the inspiration breath hold and can't hold their breath for 20 seconds, then it doesn't really help us to try that. The physician's also going to order what other scans they're going to need outside the department. And then the consent to receive treatment, which I'm not sure how exactly they do that in Ukraine, but that's a very important part here in the US, is that the patient has to, sign this legal document, this informed consent, so that they understand the risks and benefits of alternatives of the treatment. And then pregnancy test for premenopausal patients. So overall simulation, it's not exactly a surgery, but we do follow very similar safety principles, and that we involve the patient, who I would say is the most invested partner in the care of the patients, the patient themselves. So we involve the patient in making sure that they're knowing what they're here for, and we talk about laterality, making sure we're getting them set up for the correct side, like the right lung versus left lung, or the right part of the spine, or etc. So we involve the patient in the team, and that's going to particularly come into play for SBRT, where we're doing studies of respiratory motion. So a general simulation principle that I feel that we handle very, very well at Stanford is making sure the patient's comfortable. And this is not just a human thing to do, but the more comfortable the patient is, the more compliant and relaxed they'll be during their treatment, which is important, because if the patient moves, then sometimes we have to start over. I'd just like to suggest using a 2 centimeter foam mat under all patients, like we do at Stanford, because those radiation treatment tables are hard and the pads have minimal attenuation. So wherever there isn't a vac bag or a mask headrest under the patient, we're using a 2 centimeter foam pad. So stereotactic radiosurgery just means a high dose of radiation delivered in one or a few fractions to the brain area. So historically, we used this stereotactic frame, which has been colloquially referred to as a halo, in my experience, which actually uses these four pointed screws that, where I worked at in Wisconsin, were placed by a neurosurgeon, because those four screws actually pierce the outer table of the skull. And it's very rigid and very, very solid setup. And that was developed, as you probably most know, a while back, I believe in the 60s, for the Gamma Knife system. And, it's used up until, the early 2010s. I mean, I'm sure some places still use it, but this is where the word stereotactic comes from. And stereotactic just describes this system where I'm going to annotate, where this overlay is put onto the patient during the scan, which contains these different geometric radiopaque markers, and that is actually the stereotactic system. So that's rigidly affixed to this halo, and then when scanned, these show here in the scan. And so that allows for a very solid ability to relate where the tumor is in relation to these markers. But we don't really use this anymore, not at Stanford. And we use frameless targeting. And the reason why we're able to do that now is because the imaging and the tracking has gotten so much better than it was, 20, 30 years ago. But SRS is not new. So here's what we use at Stanford for immobilization. We just use these two systems of masks. So the system on the left is called the QFix Encompass, and it uses a double mask, one in the front, one in the back, that has these shims that can be tightened and loosened depending on how well the mask is fitting. Usually we don't have to adjust them. So the reason we use this mask is because of the double mask. There's not a lot of room for the patient to nod. And by the way, just while I'm talking about this slide, just try nodding your head just a couple millimeters up and down, like nod your head as little as you can. Well, that amount could actually throw off a target in the halo or the stereotactic frame that I showed you before. That wouldn't be possible, but with these masks, it is. So there's this open frame cutout in the face here, and we use that with the Align RT surface monitoring system that can turn the beam off or gate the treatment if the patient moves. Now, CyberKnife, we use another type of mask that is really not very rigid at all, and it actually has quite a bit of play in it. And this is just a kind of mask that we would use for any treatments to like the brain, whole brain, things like that, or partial brain. So it does provide a decent amount of immobilization, but in this mask, the patient will be able to move their chin a little more. We use a bubble sheet underneath the patient's head, which I think is a wonderful hack to give the patient comfort on these solid plastic headrests, but also we can use it as a shim. So we can actually, if the mask is too tight, we can take that out and it'll allow the patient a little more comfort. Now, these masks that we use for CyberKnife, they, like I said, they're a little more movable in there. Um, so I'll get back to that in a few moments. Let's talk about imaging for the SRS. The MRIs are done in the diagnostic department for fusion, and I provided in some examples of some of the MRIs that are ordered with these different SRS diagnoses, which you'll hear about, I believe, in a subsequent lecture later on, but I'm not going to get into the different types of diagnoses for SRS since we simulate them mostly the same, other than the doctor will order these different sequences of MRIs, and you can see that there's a lot of different sequences. But for the CT, we're going to go for a 1 millimeter slice thickness. Some places will do less than that. We do 1 millimeter, and we want to capture all the immobilization, all the skull, and the top of the shoulders, ideally, which just helps with the CyberKnife planning. But we also want our field of view to be fairly clipped in. We don't want to have a whole lot of space that's not giving us any information about the patient, because that's going to help with the planning by giving us better resolution. So the way SRS is delivered, and Lori's going to touch on this later, is that CyberKnife has KV image tracking. So every certain number of monitor units, I don't know offhand what it is, but I believe it's like, it's every say 50 monitor units or something like that. The KV images, which are here in the fixed to the ceiling, are constantly taking images of the patient's skull. And then the system tracks the skull position compared to the planned position and can make adjustments to the treatment plan on the fly on the Linac head. So if the patient's head is pitched or tilted, the robotically mounted Linac will adjust based on those positions, based on the thresholds set by the team. So it's a very elegant way to treat, and that's why we are able to use those masks that aren't quite as rigid because the system accounts for any movement. So you can see that that's just a world of difference from where we were with having a neurosurgeon in the department to place the frame, although neurosurgeons are involved with the cyberknife treatments as well. It's a lot less labor intensive to treat this way. Now, occasionally we will have a patient who needs to be treated on the TrueBeam with SRS. Most recently, we had a young patient whose skull bones were not dense enough for the cyberknife tracking to pick up on, so we treated on TrueBeam. So that's a VMAT treatment, non-coplanar, and we use those other masks that I was talking about earlier. And there's a video on this one, so I thought I'd just play that video. But this picture here that looks pink, that's just a screenshot from the surface guided um, system. So because the skull's attached to the nose and the bridge of the nose and the nasion and the glabella, the areas here, these areas in the face, this open mask allows a high degree of tracking ability. So if the patient's face moves during that treatment, the beam can be gated off. So even though it's not as rigid of a setup as the frame, it allows the same accuracy because if the patient's face moves, the beam goes off. Speaking of tracking, so a lot of what we do in SRS and SBRT is related to these systems, these stereoscopic infrared cameras, which can track these little radioluminescent balls. And then this picture that I'm annotating right now, where the lady has a bite block, this is a bit of an older method for tracking with SRS that doesn't involve the frame. So there's a custom bite block made like a dental mold that she bites on. And these balls are fixed there in place, and the system is calibrated in order to make sure that if the patient moves at all during the treatment, the beam will gate off. Same thing. But these are also calibrated and verified with IGRT. I don't think I mentioned that so far, but everything will have some sort of IGRT component. So this is just a video on the right side of the Align RT system, like we use at Stanford, which I think is a great system. It's very versatile. You can use it in other services besides SBRT and SRS as well. Okay, so let me clear my annotation and do our first question. Not exactly a simulation question, but just to kind of hammer the point home about our need to be accurate. According to the report, the TG-142, which will be cited at the end of this talk, for a SRS linear accelerator, what is the acceptable limits for coincidence of mechanical and radiation isocenters? So I know the answer because I did the presentation.
Yeah, so we will wait until approximately 80% participate because that's how we take attendance. So we encourage everyone to answer the question. So we have 77, 80. Yes, we hit the limit. Okay, more people are answering. That's great. So we have 86% participating and majority by a thin margin, 47% answered 1 millimeter from baseline. I'm ending the poll and sharing the result. So would you like to comment?
Yes, and I saw that most everyone either answered half a millimeter or a full millimeter. The limit is a full millimeter. I think the goal is for the physicists to get that under a half a millimeter if possible. You all can probably speak more to that. But I just thought that was a great question which kind of gives a sense of the kind of precision we're looking for with these treatments, um, and why we need to do such measures to make sure that the patient's positioned precisely. Because it could be, without a robust program, it could be fairly simple to get a geometric miss with a lot of these targets, which are so small.
Yeah, excellent.
Okay. So the quick SBRT overview. Not that I think we need to go over this too much because I know there's a lot of other lectures going on, but SBRT is just like SRS, it's just not inside of the head. Otherwise, similar concepts. The concept of oligometastasis is pretty big. There are a lot of sites that we treat that are not the primary area, but I'd say lung, upper abdomen, prostate, spine are like probably the most frequent SBRT treatments, but also oligometastasis, which could be a lot of different places. In this example, it's in the patient's rib. But because of all of the advances in treatment, the metastasis is not as dire as it used to be, and we can still have a great quality of life for these patients for a long time. So for SBRT immobilization is going to be a little bit more varied than the SRS immobilization. We use a lot of vacuum bags, which you'll see. And I wanted to mention on this slide that if we have the patient up in a vacuum bag, like down here, we do usually try to get their arms up for most areas, but it's not 100% necessary. So if the patient has some comorbidity, like a rotator cuff injury, or maybe the patient's just very elderly and very not very flexible, it's okay and even probably preferable to simulate them with their arms at their side. And I'm afraid I don't have a good picture of patients with their arms at their side, but you'd have their arm at their side, well defined in this vacuum bag. The other thing about this slide is that I want to mention is this is a picture of one of the first SBRT immobilization devices called a body frame. And body frame is a term that's used a lot in the literature, but I consider this kind of thing to be what is like a true body frame, and that it has a vacuum bag component, but it also has this device on the side which contains those radio opaque markers similar to that accessory that goes on top of the halo, and that contains those markers so that when SBRT was being developed in the early 2000s, we didn't have as good of onboard imaging. So similarly to the way that the tumor location was referenced to the halo. They were referencing that location to these markers. So I consider this the full body frame, and I have never seen it because it was before my time in radiation therapy. But I believe it's not a bad way to treat a patient, but it's probably unnecessary in the day and age of that we have 6 degree of freedom couches and onboard imaging, cone beam CT. So it's a little much, I think, for the modern era. So this device here, um, is a commercially available device, with actually you're seeing like all the accessories available on this device. And it's kind of the successor to the body frame. And I think in some literature they refer to it as body frame, but it has the option to do abdominal compression with this bridge that kind of has this adjustable inflatable thing that pushes under the xiphoid, so into the upper abdomen, or this belt. And this is what we use at Stanford if we are using this immobilization. We like the belt, which is really well customizable to the patient. What you're seeing here is another bridge that contains a vacuum bag, so to basically fix the patient's thighs in place. And I think for a program starting out with SBRT, that a system like this, of which there's several commercially available, I think this would be an ideal system for SBRT, because you can kind of start out with a high degree of immobilization and then see what's working, but start off with conservatively. Down here is another system for abdominal compression. That gets cold on the patient. So there's like a cellophane over the patient and there's a vacuum hose. You can kind of see it. It's like a white long tube over the patient. And that actually kind of not, I mean, it vacuums. It's not as strong as a vacuum, like if you vacuum seal your food, but it's enough to encourage the patient not to move. In this system, you see in this picture, there's that bridge also over the patient. I played a video of a cine of this patient's scan, and this patient had abdominal compression, and you can see that the diaphragm is moving a little bit, but if you even look at the sagittal, you can actually see where um, the belt is over the abdomen is kind of like cinching in the um, patient's abdomen. So what this does is it's not going to eliminate respiratory motion of targets entirely, but it's going to limit them. So if you're unsure about your ability to track the tumor during treatment, abdominal compression could also be very helpful in starting a new SBRT program. And we specifically use it at Stanford for one of the machines that doesn't have tracking for treatment. So for our imaging, we're gonna usually have some outside scans from diagnostic, whether it be PET CT or MRI, and that will vary a lot between the different sites of what we're fusing. And then as far as CT goes, usually for most sites, there's actually only two examples I can think of, but if there's preparation before treatment or before simulation for a conventional treatment, it's going to be the same or even more, a little bit more for SBRT. Like for our prostate patients, we have them come in with their bladder full, and we encourage them to have an empty rectum for simulation. But if they're getting SBRT, we make sure to give them an enema, because it has to be like really empty. And then they'll end up getting that before the treatments as well. So at Stanford, we use between 1 to 2 millimeters of CT slice thickness. Sometimes I've seen in the literature up to 3 millimeters, but we use 1 to 2. And then there's usually for scans in the thorax and abdomen, we're going to have more than one type of series, more than one type of CT scan. For most SBRT sites, we're going to use IV contrast if the patient can have it, iodinated contrast. And then if we're treating in the mediastinum or sometimes around the stomach, in those areas, we might use some oral contrast for the esophagus. This is just, I thought I'd include this in the slide in case anyone needed it. This is the contrast tables we use for IV contrast, and has some good information on there. Basically, we're not using the same bolus of contrast for all different sites and for all patient weights. There's going to be a varying amount of contrast and injection rate, as well as delay before the CT scan. For our respiratory motion scans, we're using the variant RGSC system, which is called respiratory gating for scanners. And this system has an infrared camera either mounted on the table or we have it Mars mounted on the wall. But the camera watches the motion of this block. And so that correlates with the patient's internal organ motion. And then we also have this screen the patient can watch, and it can kind of show them a little picture of where they're breathing. So this watches the amplitude of the abdomen as a surrogate for the internal motion. Then, of course, we have to verify that with our scans. So a lot of times, for instance, for a lung or for an upper abdomen tumor, we'll have to do a free breathing scan, which is called a 4D CT scan, that we will reconstruct the patient's motion, and it will also dissect that information so that we have basically a CT scan of 10 different phases. And I'll talk a little bit more about that. We also have an exhale breath hold and an inhale breath hold. And for those, we like to coach the patient. So if I was doing a scan right now, I would tell the patient, okay, what we want you to do is breathe out and then breathe in to a comfortably deep position and hold your breath. So some patients' lung volume, a deep breath could mean that they'll expand their lung capacity 3 to 4 times the volume of a regular breath. We don't need any Olympian divers for these types of breath holds. We want a good, healthy breath in, definitely more than what a normal breath is, but we also want it to be reproducible. So if patients are breathing in literally as deeply as they can, they are also more likely to shift inside their mobilization. They're also more likely to arch their back, those kind of things. So we need it to be controlled. So this is something that particularly takes a lot of coaching. Now, we also do an exhale breath hold scan, and we at Stanford don't usually actually have our patients hold their breath out for treatment, although some centers do. But what we use this scan for is for if we're doing what's called an amplitude based gating during treatment, we'll want to gate the treatment around the full exhale. So when the diaphragm is in the most superior position. So again, for this, since we're going to be treating the patient based on a natural breath out, we don't want the patient blowing all their breath out because a natural exhale isn't blowing everything out. A natural exhale is just when your breath empties, just pause your breath there. So that's how we coach our patients. So for these 2 scans to get them accurately, it's really important to take some time with the patient beforehand and make sure that they know how to do it and that they have a chance to practice, because nobody likes to go on stage right away and have to perform. You have to practice a little bit. This slide's a little tiny bit misleading, but it was a good picture, I thought. But this describes the phases of breathing. So when we're doing our 4D scan, we can call this the 0, and then this is the 50. So 0 would be the inhale, and 50 would be the exhale. And then this is like 10, etc. And then this is 90. So what I don't like about this slide is that the 90 is the same color as the 10. And let's say this is the 30, and is the same color as the 70. They should actually be different colors, because when we do the 4D scan, that we're gonna the software, the scanner is gonna split this up in, I'm trying to make that a straight line, but it's not. So this is gonna split into 10 different images, and we call them binned images. And you have to have some sort of a system that accounts for the patient's breathing. So we're gonna have you can customize it different ways too. You could split it up based on the phase or the amplitude. We split it up based on the phase. Let me clear those. And this is very important for being able to see how the tumor's moving. So for this example, This patient was a SBRT patient in the right middle lobe, and you can see that the tumor's circled by that's the PTV that's circling the tumor. This is just to get you oriented. In the next slide, I'm going to show the motion. And so in this, what's called a cine image, this is just showing each of those 10 phases that was reconstructed in sequence to kind of play a little movie. This one's a tiny bit choppy, but I liked it because you can actually see the movement. So if that's the PTV for this target, you can see it actually doesn't, the tumor, what I think is the tumor doesn't actually leave that target, but our goal during SBRT delivery is to keep that tumor inside the middle of the target. So for this patient, I'm pretty sure this patient had their gating with the exhalation. So you could see like we'll typically gate like from either like 30 to 70, like down in here. So that means the beam will be on when the patient's in exhale. We also do these special protocols, biphasic and triphasic. These are specific to upper GI tumors, and they kind of take advantage of the fact that some of those tumors have either hypervascular or hypovascular structure, and so they'll soak up the contrast and purge the contrast at a different rate from the surrounding tissues. So those the biphasic scans involve a breath hold. Our triphasic protocol does not. Future directions for SBRT, which I'm excited about, is the use of synthetic CT to make plans or to adapt plans. We use synthetic CT with ViewRay. So we'll have our treatment planning scan, and then we'll use the geometry from the patient's position. And then using the Hounsfield information from the treatment planning scan, combined with the Hounsfield from an on-table image, be it cone beam or MR, then we can make our synthetic CT that can be used for treatment planning. And this is how we do treatment planning on ViewRay for most of our upper abdominal SBRT. And I'm sorry, I think I've gone over a little bit. So quick summary, this physical stereotactic structures were traditionally used for localization and quality assurance, but we're replacing these with live imaging and tracking. We need to have a robust method to ensure quality and safety. And if there's one thing to take home, degree of immobilization is inversely related to how accurately you can correct the patient's position from simulation to treatment, and how accurately and how quickly you can target the tracking of the tumor. So I guess we're on to our next question. And as I thought about this question, I kind of thought it was a little bit more like a trick question. So I don't think there's necessarily a right or wrong answer. So I'm not even sure I agree with what I had originally put. But so don't feel bad if you get this one wrong.
Do you mind reading the question so it's translated
Oh, sure,
also?
sure.
Mhm.
Sure. What type of immobilization is needed for SBRT to a patient with a solitary liver metastasis? Body frame, vacuum bag with abdominal compression, or no custom immobilization? And like I said, I think this is a really tricky question, and I'm not even sure. I don't even think I even covered all the material, but I'll cover it. I'll talk about it a little bit now. Why the answer is what it is, or why I think it is what it is.
Okay. So we have 81%, 85% answering. I'm ending the poll, sharing result. So majority of people, 43% answered C, option C, 2 or 3. Do you mind commenting?
Well, yeah, I would love to. I think that option C is actually probably makes sense for most centers actually. If you're doing a LINAC based SBRT, I believe it would be 2 or 3. Um, that you'd want the vacuum bag with or without abdominal compression for treatment on like a regular C-arm LINAC. And the reason why I included 4 is because on ViewRay, we don't use any custom immobilization on the MR LINAC. And that's because the LINAC coils are very cumbersome and difficult to integrate with immobilization. So what we do is we just make the patient very comfortable and we ask them not to move and we kind of cinch them in with a Velcro strap. Now, the reason why this is okay with ViewRay is because we have live MR tracking during the treatment. So we are looking at the actual tumor during treatment. The machine has software that tracks the tumor and will turn the beam off if the tumor's not in the targeted zone. So this was a little bit of a trick question. And also, I'm not sure, but there could be some places using the body frame out there with the radiopaque markers involved in there. And it's not to say that that's wrong. It just seems a little old fashioned, but a lot of the systems are still kind of referred to as a body frame, even though I don't think they are. So I think that actually probably you can make a justification for any of these immobilization methods, depending on how you're repositioning the patient and tracking the target during the treatment. So
Sounds good.
thank you very much.
And is this your last slide?
Yes, yes. I
Yes,
believe,
okay.
yes.
Thank you so much for a great lecture. Do you still have maybe a minute or two to answer 2 questions?
Oh, sure. Yeah.
Yeah. So one question, how do you deal with patients that have fear of masks and don't want to use the mask? What would you do in this situation?
So we start out by asking them if it's okay if we use a mask that has open eyes and an open mouth, because we have masks that come like that from the manufacturer, and you can actually just make them right. The patient never has that over their eyes or their mouth. If those kind of masks aren't available for you, you could actually make your own by just experimenting where that eye and mouth hole needs to be and cutting it out with a little rotary tool before you ever put it on the patient. You can cut it before you melt the mask. If that doesn't work, or sometimes like music, things like that, like psychological things can help tell the patient to focus on their breathing. But a lot of times, frankly, that doesn't work so good on those patients. We have them talk to the doctor, and then the doctor prescribes them like a tranquilizer of some sort. Yeah, yeah.
Okay.
There
Yeah.
are there are a fair amount of claustrophobic patients out there. Yeah.
Yeah, Lori also mentioned video distraction with avatar. That's another possibility.
That's a
Okay.
good one. Yeah.
Yeah. So I see another question from Pablo Koval. Please let us know which document you were using to produce these contrast tables that you had on one of the slides.
That 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 table is an internal system that was developed by our diagnostic radiology department.
Okay.
I think I do have one more slide actually, Natalia.
Yeah, go ahead.
Um, I have a slide of references.
Oh, great. Yeah.
So these are all AAPM reports and very, very useful for researching farther into all of the nuts and bolts of SRS and SBRT.
Thank you so much. So this is excellent slide, and I will share all the links to all these reports with the participants. So that's really, really useful information. Thank you. Thank you, Joshua, for teaching us today. Enjoy the rest of your vacation. Thank you.
Thank you.
Lori, do you want to share your slides? Yeah, looks great. You're muted.
Okay, so I'll just start. So yeah, hi, I'm Laurie. This works leaning on a lot of my prior work from my colleagues, particularly Piotr Dabrowski, Natalia Kovalchuk, and Dr. Billy Liu. I'm going to talk about some of the motion management strategies we use. So just we'll go quickly over some motivations, and then Joshua did a good job of immobilization already, and we'll talk about some details with gating and workflows and technology options. So basically, in radiotherapy, we require the patient should be in the same position as their CT simulation. And also the treatment delivery times are typically several minutes or longer. And so these two things mean that we have to manage motion. So we can sort of divide motion into kind of respiratory and non-respiratory. So around the diaphragm, there's a large amount of respiratory motion up to around 5 cm. And further away you get from the diaphragm, the less the motion is from the respiration. And then, but in other parts of the body, such as around the prostate, you get non-respiratory motion. This can be like bladder filling or bowel and rectal motion. You see here the huge change in bowel gas. And these can vary day to day and also intrafraction, like minute to minute during treatment. And these things all become more critical when you're doing SBRT and hypofractionation because you have less time that these things delivered over a shorter period of time. So there's less averaging out these effects in delivering higher dose rates typically. So there's more chance of injury or mistreatment from motion. Just an example of motion in the lungs, so close to the diaphragm, so you can see on average around 2 cm motion up to 5 cm motion. And then as you go more superior in the lung, around the hilum and the carina, you see less motion, typically around 1 cm, which is still bigger than most of our margins. Are normally 5 millimeter or less. So we need to do some motion management or add an ITV margin to it to appropriately treat things that are moving. So I discussed that already. So, and then in the kind of prostate space, I just pick an example of non-respiratory motion. So in the Mirage trial for the MI-guided Fure system, they compared CT-guided treatments with no gating, which required 4 millimeter PTV margin, and compared those to MRI-guided treatments, which used gating to limit the motion of the prostate during the beam on, and that allowed them to use 2 millimeter PTV margins, and they see lower late grade GU toxicities when you do MRI guided with tighter margins. And this data was also retrospectively analyzed, and they see with the gating system that they limited the prostate motion to 2.9 millimeter, whereas ungated it was between 4.1 4.7 millimeter, depending on their duty cycle. So Joshua did a nice job of mobilization. I just quickly say that in Stanford we generally use minimal immobilization and prioritize patient comfort. So we'll make some custom patient devices like a vac bag or a custom mouthpiece. We typically won't use any immobilization in the on or any rigid immobilization in the kind of thorax abdomen area, and instead, in general, we prefer to use gating and visual coaching with or without surface imaging. And Joshua did mention compression belt. We do have compression belt, but we don't use it very often. It's not very comfortable, and you have to be careful about making it tight enough that it's reducing the motion, but not too tight that it's uncomfortable, and it has to have consistent tightness between simulation and treatments. It's also with the bridge type compression, you can't treat through, or that you need to account for the attenuation of the bridge. So for some of these reasons, immobilization devices in general add complexity, and discomfort to the patient. Whereas if you can use gating and motion management strategies that don't use rigid devices, you generally get better patient compliance. And so with that, we can move to talk in more detail about gating. So many gating systems use surface surrogates. So the variant RPM, IGSC, and Joshua mentions, and there's 3D surface imaging systems such as Vision RT or Line RT, and the Accurate synchrony system also is using surface reflectors. These all, broadly speaking, a similar approach in that the tracking motion of the patient's skin, usually with some form of reflector block, to build up a respiration trace, a motion trace, and then we have to do the tricky bit is we have to correlate that motion with the internal motion. So at CT simulation, we have to figure out what is the given motion internally versus the motion of the external marker, and set our gating windows and our margins in an appropriate and consistent manner. And so at CT simulation, we have three main options: free breathing, 4D CT, where we can capture the motion, but it may have artifacts and may be noisier, and breath hold CTs allow you to freeze the motion with higher image quality typically than a 4D CT, but not all patients can hold their breath long enough or stably enough in breath hold CT. So this is just an example of the old variant RPM system on a CT scanner. So it has a camera and a reflector block. Joshua discussed some of this already, but basically we're measuring the patient's breathing trace as we also collect the CT scan. And so what's happening is we're doing a slow CT scan where it's measuring each region of the body several times over a period of 10 or more seconds, and then also collecting the amplitude trace of the external marker, and then allows us to bin together phases that are the same, images that were collected at the same reading phase. And so some limitations are CT scans typically have approximately half-second time resolution, so very fast breathers will still have some motion in the motion blurring in the 4D CT. And at least with current software, it really requires very consistent breathing because it's stitching together multiple breaths. So ideally each breath would be the same amplitude and also the same frequency, consistent frequency. It's not too fast, not too slow. And so these constraints of the reconstruction lead us to have some artifacts in 4D CT. So sometimes you'll have wrong amplitudes stitched together. So if, for example, the patient first breathed relatively deeply and then later took a shallow breath and then breathed deeply again, then you'll see a glitch in the 4D CT where the diaphragm is in a different position at that phase. You can also have just missing data where if the patient breathed too slowly the scanner moved on and it didn't collect that phase and that location. So you just get interpolation issues. So for these reasons, patient compliance and coaching are critical. We really need consistent breathing to acquire optimal 4D CT. And then once you have that, we can move on to treatment. You can decide whether we're going to treat motion inclusive, which means exclude only the extreme motions. So include the full range of normal breathing. And so the orange and blue bars here are the gating windows, at which point we'll turn off the beam, and the black represents the respiration trace from the surface marker. And so this is an example of how we would do motion inclusive gating. So basically, we're still using an ITV, and we're basically generating ITV from all the phases in the 4D CT. And this is useful where there's only basically all that we're doing is turning off the beam if the patient sneezes or coughs or makes a large motion. Oh, and the benefits of this relatively minimal gating are that you can have relatively fast treatment. The beam on time is approximately 100%. And it's easy for the patients that they don't really have to do any breath hold or anything. And it's useful. We use it for small motions, usually the upper lung or further away from the diaphragm. But if we need tighter gating and tighter margins, we can use expiratory gating, where we exclude at least half the breathing amplitude. And so here the inspiration phases are outside of the gating window, and expiration is inside the gating window. So we aim typically for like a duty cycle around 50% for standard expiratory gating. And then when you contour it, we'll still draw an ITV, but only within the gating envelope. So we'll draw a smaller GITV, gated ITV, that only includes some of the phases. And then on treatment, whenever the target's outside the window, we'll beam off. And so these techniques on treatment, we're using amplitude gating, and we prefer amplitude gating on treatment over phase gating. And so the difference is, so here's the difference is with the green line is actually an example of, so this is green line is a consistent breather, consistent amplitude, and the red line is a inconsistent, irregular breather. And when you use phase gating, the blue boxes indicate the phases where we want to treat, and so where the machine will beam on. But you can see if you're looking at just the phase and not the amplitude, they can breathe very irregularly and have a large motion, and the machine will still beam on. So we don't like that about phase gating, and typically only use it for looser gating strategies because it's basically less robust against irregular breathing. So then I have a question. Do we need Natalia to bring up? Oh, yeah.
Yeah, I launched it.
Okay.
Do you mind reading it?
Okay. So let's fine. So the benefits of gated delivery include.
Oh, I think it's a wrong one, right?
Yeah, change the order. Sorry.
Oh,
Yeah.
sorry.
You have
Yeah.
to bring up the other one. One of the other ones.
Which false? Which is false? Okay, I can bring it here.
So
Is
what
this
is?
correct? No.
Sorry. Yeah.
Sorry about that.
No,
So
no,
I'll
it's my
go
fault.
back. Now let me end poll. Launch. Correct, right?
Yeah. So
Yeah, okay.
what's false about phase what is false about gated delivery? Phase gating is simpler, quicker delivery than amplitude gating. Phase gating is more robust to irregular motion than amplitude gating. Phase gating is typically only used when looser gating is sufficient. Amplitude gating is more sensitive to irregular motion than phase gating.
And so this question is negative, so it's what is false?
Yeah, sorry, it's a bit trickily written.
Яке ствердження не є правдивим? And while they are answering, there's a question in the chat. What breathing frequency period is optimal for DCT reconstruction?
Yeah, so it depends a bit on what scanner you have.
Mhm.
So if you go too fast, you'll have motion blurring, and if you go too slow, you won't capture all the phases at all the locations. So for us, a breathing period of 10 around 10 seconds, 6 RPM is slowest in the patient. We let the patient breathe, and higher than about 15 breaths per second per minute. Sorry, which is like breathing every few seconds. Then it's kind of becoming too fast for the scanner to get meaningful information. So
Okay.
often are you ready to answer?
Yeah, so we have 82% participating, and I'm ending the
Let's
poll
see.
and sharing results with everyone. So 41% answered phase gating is more robust to irregular motion than amplitude gating. Yeah,
That's correct. That's false.
correct. That's false, yes. So that's a correct
So
answer.
this is I could have just written it the other way around, but basically, yes. So we generally don't prefer phase gating on treatment because it's less robust than amplitude gating.
Yeah, I'm glad that people got it. So,
So, and another pitfall of these surrogate external markers is the correlation may not be perfect or may not be the same as it was at simulation. And so you can see here, we have this paper, they looked at internal motion versus the external marker. So the external marker being the reflector block on the skin. And you can see initially that the internal amplitudes are relatively similar to the external marker, but then become much larger, but the external marker hasn't picked up on that. And another failure mode might be that you can have phase lag or just breakdown of the correlation. So you can see the kind of out of phase, the internal external motions here are kind of out of phase. Another one we don't have a picture of right here, but a very common one is drift of the external marker too. That it might have a baseline drift where it looks like the respiration trace is gradually dropping over a period of several minutes. And so basically we have workflows to manage and check against the weakness of correlation. So very approximately our SBRT workflow would be take an initial KV pair, orthogonal KV pair of images to get the bony alignment. So mainly focusing on the bony alignment of the patient. And then take either a regular cone beam CT or gated cone beam CT to get more accurate alignment of the soft tissue of the target itself. And then we'll also take a fluoroscopy video to see verify the gating window and the target is in the gating window when the beam is on. Sometimes we'll do the fluoro before the gated cone beam CT to establish or double check the gating thresholds, but these ideally the gated thresholds come from simulation and keep them similar to the thresholds that were chosen at CT simulation. So here's an example of the fluoro guided, the check of the fluoro. So for larger targets, we can see them directly, or we can add fiducials. And you can, when the outline is red, then the beam is off. And then the outline is green, beam is on, and we can adjust this gating threshold until we're happy that the target's fully inside when the beam is on. Sometimes you can't see the target directly, so you might use the diaphragm as an internal check. If this, for example, a lung tumor is too small to see directly, or if you're treating the liver and close to the diaphragm. And so same thing, would adjust this green line, which is the gating threshold, until we're happy that things are as they were at CT simulation. So I have another question here. Okay, so the benefit of gated treatment delivery include easier for the patients and RTTs. It allows you to have reduced margins and treatment volumes. It allows for faster treatments, or gating allows for simpler CT simulation.
I think it's an easy question. And people answering very quickly. So we see almost 80%. Oh, excellent. So I'm ending the poll and sharing the results. So majority, 85% answered B, reduced margins and treatment volume.
Yeah, good job. So easy question. I just wanted to make the point that, gating is more complicated for the patient and the therapist. It's slower treatment delivery usually because the beam is off half the time. And it makes the CT simulation in particular quite more involved, longer, more complicated.
Excellent.
And a note on one requirement or limitation with free breathing amplitude gating is that it really requires your LINAC to be able to beam on and off very rapidly with low latency. And it also requires the LINAC to be able to deliver small chunks of MU very accurately. Some machines are less able to do this. And, for example, if your beam on latency is half a second and your patient's respiratory rate is high, then you're going to lose a big chunk of your beam on time just from the latency. So you really need low latency for high duty cycle, and you need the machine to be able to deliver these small chunks of MU accurately. And just one example, and if you can't do that, then you're basically limited to breath hold techniques or compression or immobilization techniques. So one example is this the U-Ray MRI guided radiotherapy system. So without any motion, this is the gamma pass rate, it's an indication of how accurately the machine is delivering radiation. So without any motion, we get 99% pass rate. And then if we have a expiratory gating, so gating around expiration with a breathing rate of a breathing cycle of 6 seconds, we still get 91% pass rate, which is just about acceptable. But then if the patient is breathing or phantom is breathing faster, and we're gating around expiration, if they're breathing every 4 seconds, then we get a lower pass rate, and this 76% pass rate would be unacceptable delivery accuracy for us. And then if we try to gate around inspiration instead of expiration, this is more challenging usually because patients spend less time at inspiration than expiration during free breathing. Then we get a gamma pass rate of much lower, 40%. So that's not acceptable. And so this is one of the main reasons why, at least on the ViewRay MRI-guided radiotherapy system, we prefer to do breath hold gating. And so let's talk a bit about breath hold workflows. So you can do either inhale or exhale breath hold. And we've set our gating thresholds typically a couple millimeters around the breath hold. And for SBRT, we're typically set around a bit tighter than non-SBRT, around 2 millimeters. And so the limitations of breath hold is it requires more patient compliance. They have to be able to hold their breath. They have to understand the visual or audio instructions to hold their breath. But it's good for large motions close to the diaphragm, particularly liver, pancreas, and lower lung. But it's very important to assess the patient, and and in the SRS SBRT setting, it's more critical to reduce those margins with the breath hold. The treatment delivery times can be fast with breath hold, faster than amplitude gating, just because depending on the patient, but most patients can hold their breath for 20-30 seconds, and so we can get the delivery done within a few breath holds. But the assessment becomes very important. So there's a few aspects for good quality breath hold treatments. One is the patient can hold their breath for a long duration, and often we use oxygenation to help with that. So it can increase the breath hold duration by about 40%. And we're looking for a good amplitude of breath hold, about 1 cm above the normal inspiration level. Sometimes patients breathe a little bit too deeply at simulation and they're not able to keep it up and repeat it many times. And so we also look for stability of the breath hold line and reproducibility. So ideally, we ask them to reproduce their breath hold at least 3 times to check that they're able to consistently do it before we even CT scan or treat. And so with breath hold, we also have this extra toy, which is a visual coaching device. So you can see here, we'll ask the patient to breathe in and hold their breath. And what the patient sees on the visual coaching device is a yellow bar that changes from blue to yellow when they're in the correct gating window. And so it's important to get the amplitude of the breath hold thresholds set at simulation and match what was set at simulation on treatment. Something in the ViewRay space with the MR guidance, we can do something similar. The advantage of the ViewRay is there's no surface surrogate marker, so we don't have to be worried too much about correlation because we're looking directly at the target usually, and we can gate and track directly on the target on this cine MRI, on the sagittal slice of the MRI. We do need to check that we have high confidence that there's good contrast around our tracking structure, but it's usually good. And typical workflow would be a 3 millimeter expansion, and then whenever the target's outside that 3 millimeter margin gating window, then we'll turn off the beam. And so the ViewRay works best at 4 frames per second, so we're gating 4 times a second. So I have one more question here. The question is, what's false about breath hold treatments? So what is false about breath hold treatments? Breath hold requires consistent gating threshold settings between simulation and treatment. Breath hold gating will typically result in faster treatment, a higher duty cycle, and amplitude of phase gating. expiratory breath hold has better patient compliance than inspiration breath hold. Breath hold requires patients to be able to hold their breath for at least the length of the stimulation CT scan, around 20 seconds. So what is false, what is negative?
So what is false? And there was a question in a chat about CRAD system. Are you familiar with CRAD and how does it compare
Yeah, so
with other products?
yeah, I'm talking mainly about our variant RGSC, but yeah, so there are surface guidance systems, surface imaging systems. They're a bit more advanced than what I'm showing here in that they can measure the whole surface. But in terms of gating, it's kind of the same workflow. You're using the surface as a surrogate for internal motion. So you have the same limitations, same problems. What surface guidance is good at is speeding up the setup because things like elbows and kind of position, it's a very good tool for allowing therapists to more quickly set the patient up closer to the final imaging position. I can
Okay.
talk. I have a few slides if I have any
Oh,
time.
excellent. Yeah. So we have 85% answering and actually results are split. So we have
What's
option
particular bit?
B and C, 44% answered each. So do you mind commenting?
Yeah, this was a little bit unfair because I didn't really talk much about it. So, uh, we typically avoid expiration breath hold, and we generally prefer inspiration breath hold for treatments, and that's just because some patients are not able to hold at expiration very easily, and sometimes they'll tell you they're holding expiration, but it's really an inspiration. Whereas in general, inspiration breath hold is easier and comes more naturally to patients than expiration breath hold.
Do you mind talking about option B? Why it's not the correct answer?
Oh, because it's false. What's false about breath hold treatments? Breath hold will generally be faster than amplitude or phase gating because the patient is usually able to hold their breath for a pretty long time, and so the beam is on for most of the time. They're usually able to hold their breath longer than they need to recover, so that they'll hold
What's
it.
oxygen support, I guess?
Yeah, maybe, yeah, but
Mhm.
typically, anyway.
Yeah, sounds good.
Yeah, a B is maybe a little bit questionable. It's not very clear cut, but it's usually is faster. Breath hold delivery is usually faster than gating, especially if you need a tight margins and a tight gating window. So I didn't really talk much about spirometry, but basically instead of these surface reflector blocks, you can also do spirometry. There's a Electa ABC system and there's the SDX system, a few different, but they work more or less similarly in that they measure the air in and out of the lung. The drawback is you have to have a good seal, so you have to close the nose and seal the mouth to have accurate spirometry measurement of the lung volume. Otherwise, you'll be drifting off from your expected position because you're leaking air. And the patient compliance in general is pretty low with spirometry. It's kind of forcing air in and out of the lung. It's not very comfortable. So there's some of the reasons we try and avoid it. But it is useful if you have no other options. Like, part of the reason I like to do it, I think, is because their beam on latency is longer than the variant system. And so it's better to have spirometry than free breathing for them. So there was a question about surface imaging. I kind of skipped because Joshua talked a bit about it, but there is a few different manufacturers surface guided imaging systems. and these use 3D cameras to map the patient's surface. So instead of just a single reflector block motion, now we can have the whole surface of the patient measured. And it's very useful for checking things like arm position and allows you to set up very close to the final imaging position, so you don't need as much free imaging. But in terms of respiratory gating, it kind of has the same pitfalls in that it's a surface surrogate trying to correlate with internal motion. Just one more slide on SGLC, or surface guided radiotherapy. So like I said, it's a good setup tool, allows you to speed up alignment, particularly useful for breast. And we use also for SRS treatments where we rotate the couch and then we can no longer take cone beam CT scans when the couch is rotated. So we can still take surface imaging, and so we use that as a consistency check that the patient hasn't moved. What's nice about surface guided imaging is it's continually looking at the patient all the time, so you can see all the time whether the patient's moved or not moved. So I so I covered some of the motivations. Joshua mainly covered the immobilization. I tried to discuss some of our gating workflows in detail and talked a little bit about the technology. So I think I can just stop there. Go back.
Okay, thank you so much, Lori.
Yeah.
Thank you for a great presentation. Do you mind talking a little bit about IGRT and IGRT policy, at least at Stanford, what it is for SBRT?
Yeah.
Don't know if you have
I had
slides.
I didn't do much detail. Yeah, sorry. So
Yeah.
typically so we'll do a cone beam CT as a main alignment, and if those shifts are bigger than 2 mm or 1 degree, then we'll have to take another cone beam CT just to check that the patient is shifted correctly and they haven't deformed. Particularly when you change the pitch and roll of the patient might flop or deform slightly, such that that correction that you think got you to the correct position may not be perfectly aligned, and then you need to take one more cone beam CT to double check. The
And for SRS, brain SRS on the linear accelerator.
Oh yeah. So I didn't cover too much brain SRS. So brain SRS we'll do the same, and then the main difference is we have much tighter tolerance, right? So we have a 1 mm tolerance, and so to help us out, we also throwing in couch kicks, couch rotations, to get more conformal treatment volume. And so first off, they'll be in that double mask that Joshua showed with a posterior and anterior mask. So that'll keep them relatively still. And then second, we'll use the surface imaging on the open portion of the face. There's an open face mask with it, and we'll use surface guided imaging. We're using the Line RT system, and that will help us confirm that the patient is not moved since our last cone beam CT. So we'll take our cone beam CT, has established that we're happy with the alignment within 1 mm, and then we'll be continuously tracking any motion. We'll zero out the Vision RT surface guidance immediately after the cone beam CT shifts, and then we'll check if the patient moves at all since that last cone beam CT. We'll see it on the surface guidance.
Okay, thank you, Lori. So I would encourage everyone to ask questions, either type it in the chat, or you can also turn on the microphone camera and ask a question. In the meantime, the situation in Ukraine is such that There are very few centers that even have a 4D CT capabilities. And how would you recommend them to go about treating, let's say, Alana's BRT? How would you do it without these capabilities and motion management?
Yeah. So basically, you can still do breath holds without a 4D CT. So you could do inspiration breath hold, and you could try and do a natural expiration breath hold to try and gauge at least the approximate range of motion on the CT scan. And then you can also do breath hold treatments with it gets a little tricky, and if you have gating systems on your Linac, then that would be ideal. But you still do some breath hold work without. Um, yeah. So we did that for a while. Some of our outreach sites, they didn't have 4DCT, so they would do a range of different breath holds, and
Mm-hmm.
you can also repeat your breath hold CT scans 2 or 3 times and see how consistent is the patient holding their breath and holding that same position each time.
Mm-hmm.
It can be helpful tools. Yeah.
And what about your experience with compression belts, and what's your opinion on that? So that's something that's not very expensive and can be maybe used instead of motion management for some of the
Yeah,
patients.
I think you can expect a compression belt to reduce the motion by about half.
Mm-hmm.
Right? Either a compression plate with a bridge or these pneumatic belts.
Mm-hmm.
And well, there's other devices that are kind of a hybrid of the two. And yeah, so uh, we generally don't use them all the time just because they're a little bit more cumbersome than the gating system. But yeah, you can, if you're consistently placing them and using consistent pressure, then it's been shown that they can quite significantly reduce motion by about half, and then you don't need the fancy gating requirements on the Linac to do this. You can see directly in your CT sim with the compression belt, what's the motion.
Okay, there's a question from Kirilo Telucha. Maybe you know some tips how to combine simulation CT with phase gating and treatment on Linac with amplitude gating.
Yeah, so I skipped over that a little bit. So yeah, often yeah. So one of the limitations of the CT scanner is it's spinning the 4D CT in terms of phases, but on treatment we like to do amplitude gating because it's more robust. So what we'll do is we'll set that amplitude. Well, if for example, if we're contouring the 30 to 70 phases around expiration, and we have this gated ITV that's only including the motion of the 30 to 70% phases. That is like roughly around expiration. Then we have to carefully set our gating window to match that. And although our gating window is gating it on the Linac is amplitude, we set it to such that it's the same, it's excluding the same phases as 30 to 70 phase gating.
Lori, what if a patient's amplitude changes from simulation to treatment? That can happen, right?
Yeah, so then
What do you
on
do?
on treatment, then we always verify with fluoro
Mm-hmm.
or gated cone beam CT. So on where it is, it's not the one. But yeah, so if I mean, this is a 4D, but there was a slide somewhere.
Mm-hmm.
Yeah, so
Yeah,
the
you have
fluoro,
fluoro. Mm-hmm.
yeah, so well, before we treat, we'll always do, or try and always do a quick verification. Either we'll check the fluoro or we'll sometimes now we have gated cone beam CT. We don't always need the fluoro, but basically this is a nice check that we can see that our diaphragm or our target is where we expect it to be when the gating window is on, when the Wemler beam on, and then it turns off when it moves out. And if we're not happy with the point at which the system beams off, then we can adjust the gating window on the fly, and then make it tighter, typically, so that we can so that it definitely does beam off when the diaphragm or the target is moved out of the expected location.
Okay, thank you, Lori. So I see Srihi has a hand raised. Srihi, do you want to ask a question?
Yes, thank you very much for a great presentation. It's a pleasure for me to hear a presentation from Lori as a Stanford observer also. So I do have a question about IGRT. However, my question was driven by my experience not in SRS, but in a fractionated regime. But in any case, if you can remember any clinical cases where you have to consider imaging dose from CBCT, let's say, so in our case, we had to consider when we had a PTV between the eyes and we were concerned about dose to the lens. So if you had a experience when you actually corrected your dosimetric results for organ retreat, such for lens, for example, by the imaging dose, or in some other case when that was relevant.
Yeah, that's a good point. So so for SRS SBRT, we're usually 5 fractions. And we're usually very high dose treatments. So we're usually not concerned, but for things like prostate, if we're doing daily cone beam CT, it can add up. Can be a significant additional dose, and or pediatrics, like you said, around the lens or it can it's a pretty radiosensitive organ. So we do have different imaging modes. We can image more gently with the cone beam CTs, or can take less. And one of the benefits of the surface guidance actually is that you typically have to do less imaging, because the surface guidance will get you within a couple millimeters of the final position already, and then you typically have to take less repeated X-ray or cone beam images.
Yeah, good question. Yeah.
Thank you very much. But as I understand, in those cases, that didn't lead to to re-estimate the organ, the dose to organ. So you would say this constraint is not passing now or something like that.
Yeah, we very rarely try and add it up, to be honest. It's a good question. It's not something we're overly worried about.
On clinical trials, actually, they do recommend to add imaging dose, and depending how many cone beam CTs you take, like for head and neck, and then you can correct the lens doses that way. For many fractions, right? But for SBRT, so it's less of the concern because there's less fractions.
Yep. Thank you very much. Thank you very much for answers.
Yeah, thank you. Thank you for a good question. There is also a question from Nadia Honcharenko. There are 2 questions from her. Is there a dependence of headrest for SRS treatments? What ideal tilt of the head for SRS cases?
Oh, good question. So they so I don't have much slides.
I think Josh had a slide with the SRS set up for brain in double mask. I can maybe show it. Let's see if I can pull it up.
But it's pretty neutral on the Linac. We use this Encompass mask, and we don't really go for any particular angle. I know in diagnostic they often try and tilt the head to spare the lenses, and also in CyberKnife they're a bit more restricted in the range of motion of the Linux, so they have a preferred head angle.
And another question is from Nadia as well. How do you prefer to treat vertebral bodies with hypofractionation, head first supine or prone?
Yeah, usually prone. Usually the patient is more stable. Sorry, supine. Sorry, more
Supine.
prone.
Supine
The
is
patient is
stable.
now stable. Yes, because you're lying on your bones. When you're lying on your belly, especially larger patients, they can move quite a bit. So it's best to lie supine in general. Although exceptions would be like rectal treatments where you're worried maybe more. Yes, it's more superficial and less worried about millimeter immobilization and more worried about skin toxicity.
So there's a comment from Dr. Shapil. Thank you so much for the excellent lecture. It was clear and applicable in practice. We appreciate your support for Ukraine. So on that happy note, I would like to thank Lori, also thank Josh for such a great lecture. It's very practical, lots of good tips and tricks, and we'll be translating this lecture into Ukrainian, subtitling and putting it on the website. So let's wait for that. Thank you so much, Lori. Thank you for giving such a great presentation. I'll see everybody next week. We're actually skipping the lecture because of 8 p.m. But see you in 2 weeks. Bye, everyone.
Thank you.